My dear students, welcome. On some other sessions, we were discussing penicillins. And on this session, we're going to discuss the last group of the extended spectrum penicillins, that's Amdinopenicillins. Then we'll have a look at what are the beta lactamase inhibitors, and then we'll overview the chapter of penicillins. So Amdinopenicillins is the last group of extended spectrum penicillins. For your reminder, the extended spectrum penicillins are aminopenicillins, that's ampicillin, amoxicillin. Then there are carboxypenicillins, that carbenicillin, ticarcillin. Then you have the next group, that's uridopenicillin, comprising of piperacillin, azulocillin, meslocillin. So those were the earlier three groups. And now we come to amdinopenicillins. Amdinopenicillins are mesillinam and pivmesillinam. And they are useful against resistant E. coli, Klebsiella, Shigella, and Salmonella infections. They don't have action against Pseudomonas or Proteus. So what they are doing is, in our usual sequence of organisms, as we say, E. coli, Proteus, Klebsiella, Pseudomonas. But they are useful only against E. coli, not Proteus. Then they are useful against Klebsiella, not Pseudomonas. So you can remember them alternately. E. coli and Klebsiella are sensitive, Pseudomonas and Proteus are resistant. Plus they have action against Shigella and Salmonella. They don't have any activity against gram-positive organisms. So please mind well, we are reaching the last group of penicillins, and as we are going towards right side from the left side, as we are going further and further to the extended spectrum penicillins, they are going to have more and more activity against gram-negative organisms at the cost of gram-positive organisms. So their activity is mainly against E. coli, Klebsiella, Shigella, Salmonella, not against Pseudomonas, Proteus, and not against gram-positive organisms. Mesillinam is used only intramuscular, intravenous, parenterally, and the esters, that is pivmesillinam, this is useful by oral route of administration. So we use them for urinary tract infections, typhoid fever, and for deeper infections. After amdinopenicillins, we discuss another important issue. Let's go to the next slide. That's resistance by the microorganisms against penicillins. And in the introductory modules, we discussed a lot about bacterial resistance. Let us look at it. Beta lactamase production is one of the important mechanisms practiced by the microorganisms to become resistant to penicillins. So they produce the enzyme beta lactamase, or you can also call it penicillinase, and this enzyme breaks the beta lactam ring structure. And which organisms do this? Most probably Staphylococci and the gram-negative bacilli. They practice this kind of mechanism. The next mechanism for developing resistance is structural change in penicillin binding proteins, PBPs, a structural change in PBPs. And this is practiced by MRSA, that is methicillin resistant Staphylococcus aureus. They rely on this mechanism, as well as the pneumococcus, that is Streptococcus pneumoniae, relies on this particular mechanism. The third mechanism practiced by microorganisms against penicillins is change in the porine structure, and this prevents access to the cytoplasmic membrane, and this is most commonly practiced by the Pseudomonas type of microorganisms. So that's regarding the bacterial resistance. Let's move on to penicillinase resistant penicillins, or beta lactamase resistant penicillins. Now a reminder for you, when we classified penicillins, semi-synthetic penicillins, we classified them as acid resistant penicillins, extended spectrum penicillins, and penicillinase resistant penicillins. Acid resistant is penicillin V. The extended spectrum were the ones which we just discussed, amino, carboxy, urido, and amdinopenicillins. And now we come to the third group of semi-synthetic penicillins, that's the penicillinase resistant penicillins, or beta lactamase resistant penicillins. This issue of production of beta lactamase enzyme is especially crucial as far as the Staphylococci are concerned. And naturally, if you have a drug which is resistant to the beta lactamase, then it's more likely to be useful against the resistant staphylococcal infection. And this is why penicillinase resistant penicillins are called anti-staphylococcal penicillins. Please mind well, they don't have a broader spectrum like extended spectrum penicillins. They have got a narrow spectrum of action. What are the penicillinase-resistant penicillins? The first one which was used was called methicillin, and this was used only by parenteral route, only IM, that's intramuscular or intravenous, and this drug was extremely useful those days against the staphylococci which are resistant to other penicillins. Methicillin was shown to produce certain adverse effects including hematuria and albuminuria and acute interstitial nephritis. So that is the renal damage, and this is why this drug was proven to be toxic. After a use for long years, methicillin use has been finally stopped and it has come down much, and most probably methicillin is not used these days. So it's toxic, but methicillin has got its own place in the history of chemotherapy, and it helped a lot of patients when the organism, the staphylococcus, was resistant to other penicillins. The second group are the penicillinase-resistant penicillins, which could be used by oral route as well and parenteral route, and they are oxacillin and cloxacillin. 250 to 500 milligrams could be used by oral route of administration every 6 hours, and the drug is to be given 1 hour before meals. There are other derivatives of these drugs like dicloxacillin and flucloxacillin. The third group is the newer penicillinase-resistant penicillins, nafcillin and quinacillin. These drugs are secreted in the bile, and they can also be used for infections like cholecystitis. Now, what are the uses of these drugs? These drugs will be useful if the staphylococcus is resistant and it is producing certain peculiar infections. For example, osteomyelitis, septicemia, staphylococcal endocarditis, central nervous system infections, staphylococcal pneumonia, as well as the skin and soft tissue infections. And the last one, which we just said, that's cholecystitis. So penicillinase-resistant penicillins will be mainly useful against the resistant staphylococci. There is one combination on the market, and that's called ampicillin and cloxacillin. Please pay attention to this. Ampicillin is an aminopenicillin, which is an extended spectrum, doesn't have much action against the resistant organisms, but has actions against E. coli, some proteus, salmonella, shigella, H. pylori, etc. So that's ampicillin. And cloxacillin is a penicillinase-resistant penicillin. Just now we discussed penicillinase-resistant penicillin. There's a combination available in the market, ampicillin and cloxacillin. And the people who say this is a good combination, they try to justify on the basis that cloxacillin is penicillinase resistant and ampicillin is not penicillinase resistant, so we combine. But basically, we need to understand if ampicillin has got the action on that staphylococcus. Are you going to use cloxacillin for other organisms? No. Cloxacillin has got a narrow spectrum, and you need to use it only when the organism is producing beta-lactamase. And cloxacillin can inhibit that particular organism. So if the organism is sensitive to cloxacillin, what's the need of ampicillin? What's ampicillin doing in this combination? It's not at all needed. So I'm telling you, ampicillin-cloxacillin combination is one of the irrational combinations on market. We need to mention about it because it's very commonly used by the practitioners without a rational justification, and it's available on the market. So that's ampicillin-cloxacillin, an irrational combination. Now we try to review the adverse effects of penicillins. Number 1, hypersensitivity reactions about 5 to 7%, urticaria and serum sickness. To give an example, maculopapular skin eruption by ampicillin. Anaphylaxis, which is rare, 1 to 4 in 10,000 patients, but it could be fatal, so must be remembered. Angioedema, that's lips, tongue and periorbital edema, could get precipitated. There is cross-allergenicity between penicillins and cephalosporins. So if the patient is likely to be allergic to one penicillin, the patient is likely to be allergic to all other penicillins. Similarly, if the patient is allergic or hypersensitive to penicillin, the patient is likely to be hypersensitive to cephalosporin. And the reason is the common structure, that's beta-lactam structure. Next, we cannot forget acute interstitial nephritis by methicillin, and some other penicillins also can be nephrotoxic. Gastrointestinal intolerance in the form of diarrhea and maculopapular rash with ampicillin are remarkable adverse effects. We already said about these adverse effects. Next, we move on to the other adverse effects of penicillin, and this includes superinfections. They're especially common when you are using an extended spectrum penicillin. Opportunistic fungi or bacteria can grow, and you can have pseudomembranous enterocolitis, a very typical superinfection produced by Clostridium difficile, and this is going to lead to diarrhea. Sometimes you call it antibiotic associated colitis, which is present with many antimicrobial agents. Next is Zarisch-Herxheimer reaction, and Zarisch-Herxheimer reaction is a reaction which is telling that your drug has started acting and has started producing rapid bactericidal effect. That's why the organism is liberating certain toxins, and that's why you get a reaction. So that's called Zarisch-Herxheimer reaction. Some penicillins can precipitate seizures, and they can be dangerous in patients with epilepsy. The next important adverse effect is bleeding, very typical of carbenicillin, anticarcillin, and also penicillin G. So these three drugs out of the penicillins are known to produce bleeding. And the next adverse effect, which is noted with some of the carboxypenicillins and also uridopenicillins, is eosinophilia. So these were some important adverse effects. I take you to the last topic, which is related to penicillin, and that's got beta-lactamase inhibitors. We already said production of beta-lactamase enzyme or penicillinase enzyme is one of the common mechanisms practiced by some of the microorganisms to gain resistance against penicillins. So we have already discussed the drugs which are called penicillinase-resistant penicillins, which could withstand the beta-lactamase enzyme. But there is another approach to it. Why not give a penicillin which might be destroyed by the beta-lactamase enzyme, but why not give this penicillin and give something else along with this penicillin which will inhibit the beta-lactamase enzyme? If the organism is coming up with a weapon, that's the beta-lactamase enzyme, let me create another weapon which can destroy the beta-lactamase enzyme. So these drugs are beta-lactamase inhibitors, and they are very valuable in practice. Number one is clavulanic acid. This clavulanic acid is used by oral route. It's not available parenterally. And the next is Sulbactam and Tazobactam, which are used by parenteral route of administration. What are these drugs? They destroy or inactivate beta-lactamase enzyme of class 2, 3, 4 and 5. From class 2 to 4, they destroy or inactivate the beta-lactamase enzyme from these classes. The penicillin will destroy the organism. So when you give a penicillin and a beta-lactamase inhibitor, the beta-lactamase inhibitor is going to destroy or inactivate the beta-lactamase enzyme. It's like an organism is coming with a weapon and you cut the weapon. The weapon is the beta-lactamase enzyme, and your beta-lactamase inhibitors are going to cut the weapon. So the organism remains without the weapon. Now your penicillin can attack, and penicillin can kill the microorganism. So that's the strategy. These drugs are called suicidal inhibitors. The reason is these drugs inactivate beta-lactamase enzyme, but in this process they themselves get destroyed. It's like a human bomb or suicidal bomb. So the drug inactivates the beta-lactamase enzyme, and the drug itself also gets destroyed. So we call them suicidal inhibitor. They inhibit the enzyme and themselves get inactivated. The next important keyword regarding beta-lactamase inhibitor is progressive inhibition. What does this mean? When you start using these drugs are going to inhibit the beta-lactamase enzyme. Initially, the enzyme inhibition or inactivation is not very rapid. And as these drugs go on binding more and more to the beta-lactamase enzyme, the bonding goes on becoming covalent. And the covalent bonding is difficult to break, and therefore the inhibition starts becoming more and more stronger when you go for the progressive inhibition. So it's called progressive inhibition. Initially it's slow, and later it's covalent and stronger inhibition due to the stronger binding, and this is called progressive inhibition. So that's regarding the type of inhibition these drugs are producing as far as the beta-lactamase enzyme inhibition is concerned. These drugs, beta-lactamase inhibitors, surprisingly have a beta-lactam structure. Yes, they have to have a beta-lactam structure if they want to inhibit the beta-lactamase enzyme. They have to have a similar structure to bind with the enzyme. So they have a beta-lactam structure, but please mind well, they are not beta-lactam antibiotics. So please don't include them under beta-lactam antibiotics. Beta-lactam antibiotics are penicillins, cephalosporins and other beta-lactam antibiotics, and these are beta-lactam structures, but they are not beta-lactam antibiotics because they are not going to kill the microorganism. Clavulanic acid is obtained from Streptomyces clavulicaris, and Sulbactam and Tazobactam. These two substances are synthetic. Once again, a reminder for you, beta-lactamase inhibitors, they do not kill the organism, so they are not antibacterial agents. They just protect the penicillin, and penicillin takes care of killing the microorganism. So that's regarding the beta-lactamase inhibitor. Let's go ahead and have a look which is a new beta-lactamase inhibitor. There is one substance which is a non-beta-lactam structure, but it is beta-lactamase inhibitor. I hope this information will be useful to you. Its name is NXL104. It's a new compound, NXL104. It's a non-beta-lactam structure, but it's useful as a beta-lactamase inhibitor. The beta-lactamase inhibitors are combined with other penicillins. Let's have a look at the combinations. Amoxicillin 250 milligrams plus clavulanic acid 125 milligrams. I hope you remember I just said clavulanic acid is given by oral route of administration. So you could use this combination, amoxicillin plus clavulanic acid, by oral route of administration. Ampicillin 1 gram is combined with Sulbactam 500 milligrams, and I hope you remember Sulbactam, Tazobactam cannot be given by oral route. They have to be given by injection, by parenteral route. Naturally, if you want to combine ampicillin with Sulbactam, or rather if you want to combine anything with Sulbactam, it has to be injected. So ampicillin plus Sulbactam is parenteral and is given every 6 to 8 hours. The next one is, you can choose a uridopenicillin, that's piperacillin 4 grams, and combine it with Tazobactam, 500 milligrams. So piperacillin 4 grams plus Tazobactam 500 milligrams. Again, piperacillin cannot be given by oral route, nor Tazobactam can be given by oral route. So these two drugs in combination are used by intravenous infusion every 8 hours. So the route of administration will be intravenous infusion. Finally, you can combine ticarcillin with clavulanic acid. Now, clavulanic acid can be given by oral route, but ticarcillin is a carboxypenicillin. It cannot be used by oral route of administration. Naturally, this combination, ticarcillin plus clavulanic acid, will be used by parenteral route of administration. So these are the combinations, various combinations of beta-lactamase inhibitors with different penicillins. Let's move on. Beta-lactamase inhibitors are used for some particular illnesses, for some particular infections. Number one is Staphylococcus aureus. We have been talking much about Staphylococcus, which is known to produce beta-lactamase enzyme, and H. influenzae. It's also useful against the resistant Neisseria gonorrhoeae, which are producing beta-lactamase, as well as some E. coli, which are known to produce beta-lactamase. Then Proteus, Klebsiella, Salmonella, Shigella are also becoming resistant by producing beta-lactamase. So you can use beta-lactamase inhibitors with other penicillins as a combination for all these organisms to treat diseases like peritonitis, pelvic infections, urinary infections, and respiratory infections. So also gonorrhea, burns, septicemia, hospital-acquired infections, and post-operative infections, and central nervous system infections. So this is the spectrum and the uses of the beta-lactamase inhibitor. The next slide is showing you what are the penicillins secreted in bile. I have tried to take them together so that you can remember these drugs together, which are secreted in bile. Is ampicillin, amoxicillin, uridopenicillins, ticarcillin, piperacillin, and penicillinase-resistant penicillin, nafcillin, and quinacillin. Important to remember these drugs because they are secreted in bile, and you can think of using these drugs for treating cholecystitis. The last important issue is MRSA, that's the methicillin-resistant Staphylococcus aureus. Please remember, we are coming to the end of the chapter of penicillins. And at the end of the chapter of penicillins, we talked a lot about the organism Staphylococcus aureus, which is becoming resistant. Many Staphylococcus aureus which were responding to methicillin in the beginning, they also stopped responding. So we call it methicillin-resistant Staphylococcus aureus. What are the various options? Number one is vancomycin. This is used against methicillin-resistant Staphylococcus aureus, but some Staphylococcus aureus have developed resistance to vancomycin. So you call it VRSA, resistant to vancomycin. So we have streptogramins and we have linezolid. You can try these drugs against the resistant organism, or you can have drugs like daptomycin, which can be used in place of vancomycin. There are two newer drugs under cephalosporins, and they are in the process of development. And these are 5th generation cephalosporins. That's ceftaroline and ceftobiprole. These drugs have got a promising effect against MRSA and VRSA. And the final answer could be sometimes, rarely, you could think of using rifampin, which could be useful against the MRSA and VRSA. Now we go to overview the penicillins, because the chapter was spread out in so many sessions and there are many drugs under this group. Let's have a look at it. Natural penicillins means penicillin G and its derivatives. So it's the first one is penicillin G. Next one is procaine-benzyl penicillin, procaine penicillin fortified, and benzathine penicillin. What are all these? Penicillin G was the oldest penicillin, the first penicillin, and all the three shown on this slide are the repository or depot preparations of penicillin. That's procaine-benzyl, procaine penicillin fortified, and benzathine penicillin. Benzathine penicillin was the longest acting for 3 to 4 weeks. So that's about natural penicillins. We go to the next slide, the semi-synthetic penicillins. Divided into 3 groups. One, acid-resistant penicillins, because until now, whatever penicillins we saw, natural penicillins, all of them, they were destroyed by gastric hydrochloric acid. So they were not available by oral route of administration. So the first group of semi-synthetic penicillins is acid-resistant penicillins. They can be used by oral route of administration. They are sodium and potassium phenoxyethyl and methyl salts, and all of them they together are called penicillin V. So acid-resistant penicillins is penicillin V. The next one is extended spectrum penicillins. Let us read it together. Aminopenicillins, ampicillin, amoxicillin, talampi, bacampi, and pivampicillin. Carboxypenicillins, carbonicillin and ticarcillin. Uridopenicillins, piperacillin, azulocillin and meslocillin. And amdinopenicillins, mesillinum and pivmesillinum. So that's extended spectrum. Aminopenicillins went up to E. coli, some Proteus, Salmonella shigella, H. pylori. Carboxypenicillins and uridopenicillins were anti-pseudomonal penicillins. The next group was penicillinase-resistant penicillins, and these were methicillin, oxacillin, cloxacillin, nafcillin, quinacillin. What did they do? They were resistant to the enzyme beta-lactamase. So they were useful against the beta-lactamase producing organisms. The next slide is showing you beta-lactamase inhibitors useful by parenteral route, Sulbactam, Tazobactam, and useful by oral route as well as parenteral is clavulanic acid. Let's move on to the next slide, and what I have done for you is the whole chapter of penicillin now on one slide. Left hand side, natural penicillins. In the middle, semi-synthetic penicillins, acid-resistant, extended spectrum, and penicillinase-resistant, and down the beta-lactamase inhibitor. Concentrate on this slide, keep on looking at this slide, keep on looking at the names, and I hope this slide is going to be extremely useful to you to revise your whole chapter of penicillins and all the names of penicillins. I am sure this module was useful to you and you'll make good use of this. Best of luck. Thank you.